This conference will now be recorded.
We record these meetings, we present them on YouTube. If you want anonymity, turn off your camera and/or change your name. The recording is started. It's Tuesday, August 25th. I'm sorry, it is no longer that. It is Tuesday, September 1st, 2025. Welcome to the AnCan Virtual Support Meeting for High-Risk Recurrent and Advanced Prostate Cancer. Thank you all for joining.
Except Ben, it's Monday.
Oh, that's right.
Is the
Yes.
recording on?
This is a whole new world for me. Thank you all for joining. I'm moderator Ben Nathanson, and I'm joined by moderators Len Sierra and Rick Davis, the founder of AnCan. You'll hear medical issues discussed, but we're just a bunch of guys. Nothing you hear is to be taken as medical advice. Funding for this meeting comes in part from these sponsoring companies, whom we thank: Bayer, Novartis, Johnson & Johnson, Myriad Genetics, Telix, New Earth Diagnostics, and Foundation Medicine. So Dinu is new tonight, and conversations with with newcomers start off our meeting. Appreciate your coming, Dinu. Am I pronouncing it right?
Yes, that's correct. You're pronouncing
Okay.
it right. And literally, I just found about this about 6 hours ago. And yes, where I'm calling from, it is actually Tuesday. I'm calling from Germany, and um, yeah.
So what we do is to walk you through some standard
Okay.
questions, so you don't have to think of what you have to tell us.
Okay.
Um, how old are you now?
I'm 44.
Wow.
Young.
Where do you live?
I live in Germany,
Germany.
just north of Stuttgart.
And how did you hear of AnCan?
Well, I was actually on the Mayo Clinic forum, and somebody there mentioned you guys do this, and I was like, okay, why not? It's another opinion, another option that I would like to listen to.
So so let's be sure. Thank you, Jeff. Um, so let's be sure that this is the right group for you.
Okay.
Um, so how old were you when you were diagnosed?
44. I got diagnosed literally 2 weeks ago.
Okay. But what led you to think you had prostate cancer?
Well, my father had it last year, and I said, hey, let me just get checked, and
Hmm?
yeah.
You had a high PSA?
Yes, I had a high PSA immediately after the digital rectal exam. The blood work was done, which I learned afterwards it wasn't right, but the initial blood work was 655, and the doctor jumped off the chair. I did it a few days later, and the value dropped significantly. Nonetheless, still very high, 180.
So I guess you have not yet had a biopsy.
Actually, I did.
Okay.
I went to the University of Heidelberg, their center there. I had biopsy done with 12 cylinders. Out of the 12 cylinders, 9 of them have Gleason 9 scores.
Mm-hmm.
3 of them were free, so no cancer. I also had a CT with contrast fluid done for the abdomen and the chest area. There it was, I would say, the good news. They said it's not spread. They were a little bit unsure about one lymph node, but other than that, nothing. And I also had like a bone scan, also with contrast, where they said they have not seen any spread. I'm scheduled right now. I'm kind of scrambling. I'm trying to find a PSMA PET CT scan. The earliest I got right now is in 3 weeks. So yeah, this is where I am.
Yeah, you definitely belong in this group. Sad to say.
Yes.
So what are your plans for the moment? Are you deciding between prostatectomy and radiation, or have you made up your mind?
I have not made my mind, even though the urologist at Heidelberg mentioned, because I'm high risk, he said surgery. Yesterday, I just got the chance to talk to the urology director here in the city I live at the hospital. He presented me all the pros and cons for everything, and he also suggested surgery, but he said, yeah, definitely we need to get the PSMA PET scan first.
Exactly. Yes. Yes. Yeah, I was just going to say, right. Don't do any treatment till you've seen the PSMA scan.
Right. I'm also trying to figure out a way to do. Somebody mentioned BRCA2. 3 years ago, my mother had cancer at the breast and also on the stomach. So for the stomach, they had to remove a portion of her esophagus and a portion of the top of the stomach.
Hmm.
She's clean now. My father is also clean, even though he was supposed to go in for surgery last year to remove the prostate. He had a stroke the day of the surgery, so they canceled the surgery. And then 6 months later, he ended up starting therapy. So, but so right now, like I said, my biggest up until I would say a week ago, I was pretty much trying to come to senses because everybody was saying, okay, this is super advanced, and I didn't have the results from the CT yet. I was really hard down and trying to come to senses with the fact that, hey, I'm maybe kicking the bucket pretty soon. And I was like, but luckily the CT results came out and they say, well, there's no spread. But now I'm again, yes, I'm feeling better, but it's definitely not easy. And now I have to make the decision on whether to go with the treatment or do the surgery.
And you're a Gleason 9.
Yeah, I'm a Gleason 9 on 9 out of the 12 samples. So.
I was just yeah. Why don't you have some words of wisdom? I'm sure.
4+5 or 5+4? Do you know?
They're 4+5.
Okay.
Glenn, as a Gleason 9, do you agree that Dina was at death's door?
Sorry, Ben, I didn't realize you had called on me. So, Dino, yes, I'm also a Gleason 9.
Okay.
I've been around for 11 years with that diagnosis, so you know, be of good hope, good cheer. However, I just want to caution you that with a Gleason 9 and a PSA of 180, it's possible but unlikely or improbable that the cancer hasn't spread. So when they do the PSMA, I'd be very happily surprised to learn that it still didn't pick up anything outside your prostate. But you should kind of just be aware that it's quite likely that it has gone beyond the prostate.
Quick mention. as soon as the biopsy results came out, the urologist put me on bicalutamide, 50 milligrams once a day. They said that it will slow down or potentially even stop the spread. So
That's not so good. Oh yeah.
uh,
Rick, will you?
that,
I'm sorry, Len.
I was just going to say that I would say that's a bit inadequate.
okay,
Typically, if they're going to put you on bicalutamide at all, it'll be 150 milligrams. Um, and of course, there are better. Bicalutamide is an androgen receptor blocker, and it's very old. There are much newer, more effective androgen receptor blockers that they could be prescribing. I'm not
okay.
too. I mean, I know Heidelberg is a great location for scientific excellence and such medical excellence, but I'm just a little puzzled why first they tested you and they said you were 600 something, whatever it was, and then the very next time it's 180. Something very
The
messy
600
going.
was done at the local urologist here in town where I live.
Right.
Where I just did my regular prostate exam, and then as soon as he felt it, like, okay, your prostate is a little enlarged, let's do some blood work. And then literally I sat in the waiting room for 10 minutes, and then they pulled the blood, and then
Len, they
Yeah.
did a DRE. They did a PSA right after a DRE, which
yeah,
which
pretty
Oh,
much.
oh,
which is a bit. I don't know if you know the expression bush league, but that is very bush league. I mean, any
Yeah.
urologist who takes your PSA right after he's done a DRE, he shouldn't really be treating prostate cancer.
Right, and pretty much that's where I myself, after I did a little bit of
Yeah,
research, 2 days later, I went to a local lab here and paid to get my blood done again for PSA, and that's where it
yeah,
dropped
down to 180.
to about 180. And then when I managed to get a few days later to Heidelberg, they did blood work again, and they confirmed it was 180.
Yeah, so Heidelberg's excellent for prostate. We've had people fly to Heidelberg for treatment
Okay,
with radioligand therapy. It's a really good. It's a really good center. Was it a urologist from Heidelberg that put you on the, bicalutamide?
yes, that is correct.
So the first thing I would recommend you do, if it were me, is the chat window are those two little squares next to the little man that says 35. And in that chat window, I've put a link to the MSKCC nomogram.
Okay,
Now, nomograms are usually site-specific large databases that historically record the outcomes of disease. And you can put in your disease demographics. It asks you questions, you put in your disease demographics, and then it'll tell you what the outcome will be in your situation. So you'll be able
okay,
to open that up. And by the way, you can click on that right now. It'll open up in your browser window. And
okay,
you want to run the pre-radical prostatectomy nomogram. And what it's going to
Okay.
tell you is how likely it is that the disease has not spread. And that gives you a really good idea as to whether you'll need treatment after the radical prostatectomy. Now,
okay,
the experience of this group with numbers like yours is that probably you're going to be, it's probably going to be in the 90, there's a 90% chance that you'll need treatment. There's probably a 10% or less chance that you don't need treatment.
okay,
When I ran it back in the day for myself, I was 56. It was there was a 70% chance that I would need treatment, a 30% chance that the surgery alone would be successful.
Okay.
So the other issue is, well, even if I just had the radiation, would the surgery still help me? In other words, is it worth my while going through the side effects of the hormone therapy, the radiation, and the surgery? We don't really know. We don't have those statistics. It probably makes about a 4% difference. You know, at age 44, with advanced, with a high risk diagnosis, that 4% might sound pretty good compared to, say, somebody who's 60. So
Okay.
it isn't that it's the surgery isn't going to help. It's that most likely you're going to have to do other things. And there are a bunch of men who will talk up in a moment who said, gosh, if we would have known that surgery alone wasn't going to help us, we wouldn't have done the surgery. But your situation may be a little different. And you need to discuss that. You need to discuss that with the urologist. So, you know, these are the sorts of things. Somebody's asking me, will the bicalutamide mess up the PSMA? No, it won't. Not with 180. I suspect the reason he gave you the bicalutamide is because he wants to give you a Lupron shot. And you need 15 days worth, and he doesn't want to waste time. So that I'm waiting for you to make a decision, because we often give bicalutamide as what's called a buffer, because certain types of androgen deprivation therapy, what are called
agonists.
Agonist LHRH, they boost your testosterone before they reduce it. And so we give bicalutamide as a buffer to protect you. And we only give it, how many days worth of bicalutamide did he give you?
He gave me 30 pills, so 30 days.
So he gave you 30 days. So, yeah, I mean, I'm thinking he wants you, he's sort of giving this to you whilst you're making a decision. I would give him the balance of the doubt, especially if he's a urological oncologist from Heidelberg.
Okay.
So, you know, as you probably know, even if the PSMA is negative, that doesn't mean necessarily that you're off the hook. It can well be negative.
Yes.
So the current guidelines say that that prostatectomy and radiation are equally good. It used to be that the younger men were given prostatectomies, and the older men got radiation. So they're equivalent, but importantly, they say that if you're being offered prostatectomy, that they need to tell you that you will probably need radiation after, if you have a Gleason score like yours, a high risk cancer. So you should bear that in mind. That you will need to go back, and there's been shown to be no benefit in having both. Having surgery and then radiation has not been shown to be better than just getting radiation.
Okay.
Well, Peter Carroll would disagree with you, Ben. And I don't know. I mean, I've never seen a study that compares radiation and hormone therapy to surgery radiation and hormone therapy. So if you have one, I'd love to see it. I mean, I've been looking for one of those for 18 years. The best we could ever do in terms of numbers was to get to extract a number out of Peter Carroll, and he put it at about 3 to 4% benefit marginal benefit from adding the surgery.
Okay, I was quoting what a fellow had told me way back. Okay, um,
I mean,
you can. I don't know anyone who's. You can find out. You can ask the guys who's had a prostatectomy and who's loved the outcome, who's had a radiation, who's loved the outcome. Um, I I don't view the bicalutamide quite as calmly as Rick. I don't know what's going on. If you're going to get a PET scan, they shouldn't be messing. They shouldn't be messing with your testosterone. I would I would yes. I mean, I could understand he wants to slow it, but I would want to know from the doctor. I would want to know point blank to ask him um, or her um, whether that won't mess up your PSMA. And yeah, yeah.
you know, Henry seems to think it might do. Here's my thinking on this: if you've got a PSA of 180 and you just started bicalutamide, which is not going to affect your testosterone at all, but it will impact your androgen receptors, but not particularly well because it's an old drug. My guess is that if you're going to do a PSMA in short order, it's not going to make a huge difference. If you took bicalutamide for 3 months and then did a PSMA, yeah, I could see it. But if
So
taking bicalutamide for a week or so, is that going to change? I mean, it could do, but I don't think it would make a huge difference.
Quick question: how long, if let's say, because my PSMA PET scan is scheduled for the 22nd, so by that time I'll be pretty much almost on a month
Right.
on bicalutamide. How fast do the levels readjust? Let's say if I stop for like 3-4 days before it, will the levels adjust, or
No.
does it also need like a gradual?
So here's the problem, Dino. Bicalutamide won't reduce your testosterone because it works in a different way.
Okay.
Think of it as a key that goes into a lock, and the lock are your androgen receptors, and they are what eats the testosterone to fuel the cancer.
Okay.
And what we're doing is, what the bicalutamide is doing is it's putting a key in that lock, except it's not a very good key. It kind of shakes around a bit. It's kind of loose. And so some testosterone will get through, but some testosterone will not. I would say that if we're going to be you're going to be waiting a month, you're almost a month on it, then I would agree with Henry and I'd agree with Ben that you should reach out immediately to your urologist and ask him, is this going to impact the PSMA scan if I take the bicalutamide?
I mean,
Okay.
if your argument is that it ain't doing shit, then why even take it? And if it's not doing anything and we don't have to worry about it, then why even take it?
Well, because if he decides to do I mean, I didn't realize he was going to have to wait till the 22nd, but if he decides to do ADT a month from, very quickly, he's got to take the bicalutamide first. So it saves him the 15 days. So he's got it under his belt, so he doesn't have to worry. I mean, that's why I suspect the doc gave it to him, but I also suspect that this doctor may not have been thinking about what it would do to the PSMA scan, which is why you join a group like this, because we got smart guys like Henry and Ben who are raising this very issue.
Dennis Correa, your hand's been up.
Yeah, you had a history of family with some prostate cancer, I think you said. And
Yes, my father had it last year.
Have you had any genetic testing to see if you are carrying any genetic mutations?
Not yet. I've spoke with the urology director yesterday, and he mentioned that yes, I could do it. He said with my high score of PSA and what I've told him about my mother having breast and stomach cancer and my father having prostate cancer, there's a very high chance that there is the genetic transmission.
Yeah,
Um,
I wouldn't wait too long on that because that could impact the type of treatment that you get.
right.
The
So,
other thing that stood out, it didn't sound like you had a lot of trust in this uh, urologist here that did this work with you, and he, I'm sure, took the biopsy. I
well,
don't know
the
if he read it or that he had a radiology person read it because you might want to get a second read on those slides.
Mm.
You had a lot of 4+5s, and there's a difference if you're a 5+4 or a 4+5.
they're
And
all 4+5.
yeah, but it's an individual thing depending on the experience and so forth. And if it's a 5+4, it's different. It's a more aggressive.
Dennis, who are we going to say? He could get a second, but we can't. It's going to be too difficult for him to send it to the United States. So, we have to think about this when we're talking. It's not bad advice, but we've got to think about this when he's in Germany. I mean, yeah, I can call Dr. E and ask her. I can text Dr. E and ask her who could we get a second opinion from. But do you know somebody in Germany who's going to give him a reliable second opinion to University of Heidelberg? University of Heidelberg's a very, very good center.
Yeah.
We have to
I
think
don't know.
about advice. Dennis is right. If you were in this
It's
country,
available if you can find
we'd have
somebody.
somebody else reread your slides. But again, we don't know who to say reread. And frankly, I'm not sure I agree with Dennis either, because 4+5 or 5+4 really isn't going to make a huge difference. I mean, you can run that nomogram and you can run it as a 4+5, and then just for C, you can run it again as a 5+4, and I don't think it's going to make a huge difference. Maybe 2 or 3 points on something like yours, but I mean, it's not a bad. They ask you for your worst, so you put in 4+5 and you run the nomogram, and then you see the result, and then you just do it a second time, put in 5+4. I bet it's not more than 5 percentage points difference.
Marky, your hand
I
is
have a
up.
question for you, completely
Oh,
unrelated. With a name like Dinu, are you Romanian?
Yes, I am actually.
Am fost 5 ani la București.
Foarte bine.
1996 to 2000.
Okay.
La București. Okay.
if Marky, your
Also, I
hand's
want to
up.
give a
Oh,
quick shout out to. I've seen some of you guys are also veterans. I also did 11 years in the Navy. So.
Oh, in the U.S. Navy?
Yes, I did. I moved to US, and 5 months
Oh,
later, I joined the Navy. So.
Amen, brother.
oh,
Amen, brother.
okay. Well, listen, I know the time isn't going to work for you, but Jim Marshall can help you get a bunch of money, I think. I don't know how it works when somebody's outside the country, but does it still work, Captain Jim?
Absolutely.
Okay.
Okay.
Dino, do we have your email address? If you could just
Probably I'm gonna drop it in the chat right now.
yeah, drop it in
Good.
the chat with your last name. You can just send it to me if you want, and then I'll pass it. Jim will see it, or I'll pass it to Jim, and we'll start working with you, and hopefully we can do that. I mean, the other thing I can definitely do is I will do is we have one doc on our advisory board who really knows European treatment very well, and she's an amazing GU medical oncologist herself.
Okay.
And I will ask her who she thinks should be treating you at Heidelberg, and I'll get something out. It's her birthday today, so I've been back and forth with her. Well, we'll get to her, and I'll try and get you some guidance. So yeah, and then we'll sort you out. Unfortunately, all our meetings for you are all in the middle of the night, but our veterans meetings too. But
It's okay. Like I said, I saw this, and Jeff Marchi, he was the one that mentioned it to me in the Mayo chat, and thanks a lot. I appreciate it. And
thanks, Jeff.
again, any suggestion, any support is welcomed. Again, like I said, for me, this is super fresh, and I'm still trying to process and go through a roller coaster of emotions. But yeah, really appreciate what you guys are doing.
Speaking of Jeff Markey,
Yes,
Jeff, yeah.
I also told him about getting a PSMA PET scan a couple of days ago, and that at his age and the family history of genetic problems, it's the genetic test I recommended he get it too. One thing though, Dino, when you originally posted on Mayo, you said you had a 9, most of them Gleason 8 or 9. You didn't
Yes.
say they were all 9.
There's one, there's 8, but all the other ones are
It's not
9.
real important. I just, because the 9s are really the number, but I just wondered about that since you didn't mention it. That's all.
Jack, your hand's up. Dr.
Yeah.
Jack.
The one thing you mentioned, you know, what the intention of the physician in Heidelberg may have been, you know, the Casodex can upregulate the PSMA expression, and you know, I don't know, it's possible although he may not have needed it, he may have thought about the possibility of doing that rather than, you know, as a prelude to the Lupron injection. So it could be either one, but I just thought, I do recall that the Casodex or anything like that can make it more visible on the surface of the cell.
Okay. So in other words, so Dino, Casodex is the trade name for bicalutamide.
Right.
Okay.
And so what Jack's saying is by upregulating it, it can get the cancer to express more loudly. So maybe he's giving you this to encourage the cancer to express itself on the PSMA.
Okay.
Like we say, this is a bit above our pay grade, maybe not Dr. Jack's, but most of us, and so it definitely warrants a discussion. Just one question: how many of those cores were G9 were Gleason 4+5s?
So 8 were 4+5s, and 1 was a 4+4.
Okay.
So
Let me reopen the report right now.
Yeah, I'll reach out. I'll reach out to Dr. E. And see what we can come up with for at Heidelberg in terms of recommendation.
Yeah. Also, just drop me your email address so if I can send you the documents if anybody needs to look at them.
Oh yeah, I'd be very interested in seeing your pathology report.
Yeah, some of them are in German. I've kind of did some rough English translation, but I think it's the number that are important.
So
okay, ich spreche auch Deutsch. Ich habe viele Wörter jetzt vergessen, aber ich kann in Deutsch. Ich kann auch in Deutsch.
Sehr gut.
Besser in Deutsch als Romanisch.
You're a jack of all trades when it comes to languages. A little bit of Romanian, some German.
Yeah. But the German's better than the Romanian. The French is the best. Okay. I'm putting some email addresses in the chat window for you.
Yiddish too, Rick?
Well, I understand a fair amount, but I wouldn't say I speak it. It was the reason I took German, Ben,
Hmm.
so I could understand my grandma and my mother when they were talking about me.
Yeah, that's a familiar story. Yeah.
Okay.
Do you happen to know, Dinu, if there are any particular characteristics in the pathology report, things like cometonecrosis or ductal or intraductal
Well, I'm
figure
reading it
form,
right now, and it basically says, okay,
acinar adenocarcinoma?
the 3 tumor-free fibrous connecting tissues. Those are on the first location. Then the second location infiltrates the NCNR or infiltrates of the NCNR endocarcinoma, Gleason score 4+5. Maximum contiguous tumor extension 0.5 centimeters, tumor volume above 70%. 2 cylinders for this location. Next location, same infiltrates of NCNR under adenocarcinoma, Gleason 4+4, and maximum tumor extension 1
Oh,
centimeter.
we don't have to heal. Just if all
Yeah.
of them say acinar adenocarcinoma, or any of them, do any of them not say acinar adenocarcinoma?
No, they all say the same.
Okay.
And like I said, only one of them is 4+4. The other ones are 4+5.
Okay.
All right, Dino. Listen, we're so sorry that you got to join us, man, suddenly at 44, but we'll do everything we can. One thing I can definitely tell you, because I work with a close friend from when I lived in Bucharest, is you don't want to be treated in Romania. The level of knowledge is just not there. She happens to
Right.
have Lynch syndrome, and we've guided her on her Lynch syndrome, but it's been a real problem. So, try and stick in Germany or the United States for your treatment.
Right. I mean, I'm definitely sticking in Germany since I'm living here. Yeah, my father-in-law also had prostate cancer this year. He just got off the medication too, and he was pretty good. I mean, his Gleason scores were low. He had maybe 2 out of 12. So, but
Something else that you may not have thought of, which is really important for you at 44, and maybe important for your wife, is that before you start, I don't think that the bicalutamide as yet should prevent this. That you might want to bank some semen. I mean, I
I'm
did
okay.
that.
We already have a kid. He's 16 years old. We're not planning for anymore. So
You're not planning for any more. Okay.
no, I'm not planning for any more kids. But
Okay.
yeah, I'm aware that I will pretty much lose or I'll become infertile.
Well, you'll definitely become God willing, you won't have complete erectile dysfunction, and there are ways around that. We can talk to you around that, but you will be infertile. So if
Right.
there's any thought at all, then the better thing to do is to bank it, and then you're good.
Yeah.
Well, thank you for joining us, Dinu, and we'll continue to
Thank you all for
look
the
out for you.
support, and I'll definitely reach out to those email addresses.
And
Thank you.
and next week's meeting is 2 hours earlier. Okay.
Yes, I've seen that.
Okay. So everybody wants another meeting because our meetings are so busy. Maybe we have to have a meeting that starts at 1 in the afternoon. We do that for a couple of groups that have European connections. So maybe you could stimulate a new midday group, Dino.
Yeah.
Okay. Uh, Now to our regulars, Lee Balin, you're first.
My camera off instead of turning my mic on. Can you hear me?
Yeah.
Okay. I'll keep it as brief as I can. I'm 10 years out on radiation. I've had a lot of issues, a lot of bowel and bladder side effects. I have, at this point, a indwelling Foley catheter. It gets changed every 4 to 5 weeks. Over the past 3 or 4 years, that's been a fairly smooth process, not nearly as burdensome as it sort of sounds at the beginning. One of the nice parts is you don't have to get up and go to the John in the middle of the night because you hook up to a bag. In May, I had a 2-week long bout of painful both pressure and fullness and pain. I sort of suffered through it. I see my surgeon urologist who did the bladder fix and the catheter thing by happenstance. At the end of that, his assessment was, I've got a lot of radiation damage. It's going to happen. Up until then, I've only had a day or two or no issues with catheter changes. He recommended a product called phenazopropridine, also called Azo. It's a bladder pain relief. And what I'm looking for is anybody here who has used Azo for bladder pain relief from radiation cystitis, what your experience is, how long have you used it. Paperwork is it's almost a black box warning, don't go more than 2 days. I can't find anything that tells me particularly why. And if I get another bout of this several week long instead of a day or two long issue, can I take it, stop, take it again? So I'm looking for that sort of experience. If anybody's got it, I will be very grateful to hear what's happened with you. Silence.
No,
Deafening silence.
you say you have started to take it?
I took it. I had a more recent episode that lasted a couple of weeks. I took it toward the end of it, and I don't know. Well, it's not curative. It's strictly a pain reliever. Nobody says it helps anything. And I think I took it just as the thing was going away. So I didn't have the issue of do I need to take it longer or not. I just had a catheter change last week. I had a day or two of discomfort. I took 2 doses of Azo, which is just less than a full day. It's resolved it, or it went away. I don't know. Because my normal reaction to a catheter change is no issue, a very short day issue, occasionally 2 days or 3. We're about to go on a 17-day vacation in Peru. And my big question is, what happens if I get one of these 2-week long issues in the middle of my time in Peru? And I would love to know if I can take it 2 days, stop for 3, take it again, or if I can take it for 5 days, and any help, I'd be grateful.
Have you brought this up with your doctor?
I've tried to message him. My urologist is a brilliant surgeon. Anything he can't fix with a scalpel doesn't seem to issue him. I haven't raised it with my MO. He may know or not. I just haven't had the opportunity. But I have not gotten a response from the urologist. I'm not actively treated by the urologist. I see him every 18 months to 2 years just to stay on the book. So if I need him, I'm not a new patient. I'm a returning patient. My primary treatment is in medical oncology, not urology.
So in fact, it's not all crickets. Brian Hack has his hand up.
I'm sorry?
Brian
Hey,
Hack,
yeah,
you have your
can you
hand up?
guys hear me? Yeah, Lee, this is Brian speaking.
Yeah.
Have they ruled out a urinary tract infection?
Yeah. None of the issues. Urine's clear, no fever. I've had a couple of UTIs over the years. I tend not to get them, and
But
this did not have the earmarks of a UTI.
did they do a urinalysis?
No. It's interesting. My urologist has an interesting view on this. His view is a simple urinalysis tells you nothing because there's always bacteria in urine. Doing a 7-day culture may tell you something, but by then your UTI is probably resolved. But I'm pretty certain it's not a UTI. I know what they're like, and this had none of the attributes.
Okay.
I can, very frankly, the couple of times I've had it, I could smell it in my urine, and I've had a fever. Okay, I'm drawing a blank. I thank you for your
No,
attention.
no.
Oh.
No. People got their hands up. Rick has his hand up.
Yeah, I am thinking that Dr. John may well have good information on this because he's had his fair share of bladder issues. He's also, was trained as a pain doc, and he may well know about this. Unfortunately, he is on a flight from across the country from Vancouver back to Connecticut tonight. So I will make a note to ask him to listen to this and to reach out to you if he's got anything to contribute. But I have a feeling that of everybody that attends this group, he's probably the most likely to know something.
I would appreciate that very much. His input is always good. Look, the worst is if it happens, it happens. I've suffered through worse. So if I've got 10 days of pressure and pain in my bladder, it's not going to deter me from hiking in the Amazon or going up to Machu Picchu, because this trip to Peru has been planned for a long time, and we're not going to cancel it for a little discomfort.
God bless you, Lee. Lee, when are you leaving for Peru?
We leave Saturday morning.
Okay, I'll definitely I'll reach out to John probably in the morning because it's going to be a bit late. But I'll reach out to John in the morning and talk to him for sure for you.
I appreciate that. I'm not optimistic to get anything particular. My guess is he's going to say, take it for 2 days and stop and maybe try it again later. It seems to be a very serious warning, so I'm not going to push it.
Lee, would you please? I got the ASO, but I didn't get the generic name. Would you put it in the chat window for us, please?
Yeah, I'll put that in the chat window.
Thank you very much.
If I can I'll try to spell it right.
Jim Marshall's hand is up. Jim?
Lee, hopefully you have the travel insurance for a medical ambulance just in case, because if you're very ill, you cannot fly essentially on the airlines. You will have to be medically evacuated, and that can cost $20,000 to $25,000. So
I made a good part of my career as a lawyer was advising clients on insurance issues.
Oh, good.
So I'm very up on it, and
Great.
I've read all the fine print of travel insurance policies, and I will tell you they are very different. Read them before you pick one.
Thank you. And now, and Lee, now you tell us there's a couple of us on this call who have had insurance issues, We wish we would have heard that from you about 6 months ago.
Medical insurance is not one of my specialties, but I can read policies.
No,
And I
we're talking about homeowners insurance, Lee.
Oh, email me. I'd be happy to talk to you.
Okay. You may hear from us.
I had a tree fall in my backyard a year ago, and even I got some surprises from my not very helpful insurance company, and I've changed to. I've got it. If you're in the U.S., I have good advice on 2 insurance companies and only 2. The rest of them are.
Okay. Well, you'll probably get a couple of emails within the next couple of days, I suspect.
All right. I will be happy to respond if I'm able.
Okay.
Thank you all, gentlemen. I might bug out a little early tonight. To the gentleman from Germany, if he's still here, I just want to tell him I was diagnosed at least 9 and 10, almost 10 years ago, and I'm 82 and I'm still going strong. So there's a lot of life ahead of you.
All right, sounds good.
We did the
Sounds good, Lee.
Serengeti. Said the Serengeti last fall. We're going to Machu Picchu now. We're living large. So
Be sure to
I'll keep you as my inspiration. You're gonna be my goal.
Be sure to acclimate before you get to Cusco. I made the mistake of flying directly from Lima into Cusco. Big mistake. It's very
we have
high.
some. We've got some medication. Half of my luggage is either urinary supplies or medication. We've got Paxlovid. We've got flu stuff. We got all sorts. Last thing I want to do is get COVID in the mountains with no treatment. So I take it all with me. If I had to change a catheter, I could probably do it myself.
You're gonna love Peru.
What?
Said you're
I'm
gonna
sorry, I
love
didn't hear.
Peru.
Oh, I can't wait. We're doing a couple days in Lima, then we're going up to the Andes for 4 days, and then we're doing a cruise in the Amazon basin. So I can't wait to see it all.
Okay, thank you, Lee.
Okay,
Bob
thank you,
Alvord.
gentlemen.
Bob Alvord, you're next.
Okay. Real quick update. I want to thank AnCan and Rick personally for pointing me to UCSF. Had some issues in communication, I guess, with Sutter. So my quarterback is Dr. Rahul at UCSF, and I was referred from him to Dr. Mac Roach, and together they determined that their opinion from the scans that was oligometastatic disease in the pelvic lymph node and the L2 lumbar, which was kind of different messages that I was getting from Sutter. So since I've talked to you, everybody, it's been 5 months on Lupron and apalutamide. So same as our friend from Canada, Elaine, taking the same thing and taking the same and experiencing exactly what you're experiencing. So Dr. Rahul is the quarterback, and Dr. Roach, he referred me to Dr. Roach. But prior to all that, I developed gynecomastia and had a short term, 5 minutes each, 3 sessions of radiation to my breasts at Sutter. And skipping around a little bit here. So after getting referred to Dr. Roach from Dr. Rahul, I am scheduled for SBRT to the avid lymph nodes.
Bob, let me interrupt. So are you
Sure.
giving us an update or did you have a question?
Oh, this was an update.
Okay,
Yeah,
carry
pretty
on.
much an update because I hadn't talked about anything except for once before. So I have 11th through the 17th SBRT in L2 spine and the pelvic lymph node. So one of the one other thing too is I was scheduled to have a colonoscopy consult coming up in a week or so, and Dr. Rahul said no colonoscopy for 1 year. So that's just a FYI to folks out there.
I'm sorry, why not?
Um, he said I assumed that it had to do with enough allow for enough healing from radiation or not having any impacts from the radiation.
Mm-hmm.
He first said 6 months to 12, but he said better if it's 12 months. So I'm going to consult with the colonoscopy consult and ask that question. So everything looks to be pretty good. The other thing that I was a little bit concerned about, going back to my somatic testing that showed 2.2% TP53. I know that there's only one under the government clinicaltrials.gov. There was only one trial that dealt with TP53 and others, but it was at 2.2%. But I understand there's probably not a big concern at this time because of there's no RB1 changes. So I don't know what that means to everybody, but just from what I read. So everything looks good. So I thank Rick and everybody for pointing me to UCSF. Looks like I am progressing quite nicely. So just want to say that.
Yeah, oh, that's good to hear. Thank you, Bob.
Yep, thank you.
Tony Fig, you're next.
Hold on, I have my hand up.
Oh, that's right. Yes, please come in, Rick.
So Mac stopped me from getting a colonoscopy for round about 5 years. He does not like doing colon. He eventually, I'm trying to think. He finished the radiation in 2008, and I think about 2014 he let me do a sigmoidoscopy, and then he gave me the green light to do a colonoscopy about 2016.
Wow.
So so that's I've heard this before from that team. So don't be surprised.
Anybody else have experience with TP53 mutations and from their
Yeah,
somatic?
so we know about this TP53 trial. What's the drug, Ben? I always space it out.
I'm sorry, I don't remember.
Yeah, it's a
Isn't it?
long one.
Or am I might be thinking of P10 actually. Am I
And
thinking about P10?
this is a NICE trial.
This is a trial where?
This is called the NICE trial, according to the government.
Nice trial. Okay.
Yeah, it's a phase 1.
Yeah, there's something going on with TP53, I know. Don't think there's anything going on with RB1, but yeah. Ben, do you know anything going on with TP53? You're our man on this one.
No, I do not. That doesn't mean there isn't. I just don't know.
Yeah, so that was one of my concerns ongoing, but
So So what exactly is your TP53 situation? You have TP53 loss.
Um,
You lost
uh,
one allele.
it showed a 2.2% in Garden 360 somatic test, blood test. So I was concerned about that. I understand it's probably not a concern unless it gets over 5%. But again, I'm just kind of parroting what I've seen and read before. As far as a less positive prognosis, long-term survival, all that stuff with the TP53. But they also said if it's not in association with the what is it
RB1.
RB1 in conjunction with that it's probably not that big a concern. Seems like a good percentage of prostate cancer patients have this the TP53 mutation in the blood. I don't know if that's true or not, but I heard it's not uncommon and not a concern at this point. That's a
So
good news.
there are 3 or 4 mutations that we don't like to see: TP53, PTEN, RB1, CDK12. For the most part, the gents who only have one of those, it's not that important. It can be influential, but if you have 2 of those 4 or more, then it does become an issue. At least that's my understanding.
That's what I read as well. But you guys would know much more. So thank you. Can't thank you enough too, Rick. All I had to do was drop your name in AnCan, and I was able to self-refer myself from Sutter to UCSF. So thank you personally. Thank you.
Okay. Anybody else for Lee? I'm sorry, for Bob.
Yes, Tony here. I was wondering how you identify the mutations. Is it through somatic testing?
That's correct. Yes.
Okay.
Yes. The blood test, not the not the biopsy of the lymph nodes. That showed paraneural or something like that.
I'm wondering if that's something Dino should consider at this point, would be some the blood testing somatic.
That and the genetic for him,
Well,
for sure.
the genetic is really important for Dino.
Yeah.
It may not hurt. In fact, Dino, the way that you might want to go at this, if you can get it done, because I honestly don't know about how the labs operate in Europe. I know several of the labs do operate in Europe. Foundation Medicine does operate in Europe. Is if you if you can do first of all, you do a liquid biopsy test, which means they just take your blood, and they'll probably get a result with a PSA as high as yours right now. There's a good chance that they'll get a result from circulating tumor DNA. And then if a mutation shows up, that could also be an inherited mutation. So let's just say you do this and it shows BRCA1, BRCA2, okay?
Okay.
You then will have to go back and do the inherited test and see if the BRCA2 also shows up in the inherited test. If nothing shows up in the somatic liquid biopsy, then you don't have to worry about doing the inherited test.
Okay.
We recommend that sequence because rather than doing it the other way around, because there's a chance that we may not see anything, because not all these mutations that show are necessarily inherited. You make them yourself. And just because you make it yourself doesn't mean it's inherited, because some of these mutations are not inherited. But if you were to see something like the ones I mentioned, TP53 or P10 or some of the Lynch syndrome, MSH3 or MSH6 or MSL1 or any of those, then you'd have to go back and do your germline test, your inherited test as well.
Okay, so what was this? Was called foundation medicine? You
So
mentioned.
foundation medicine definitely covers Europe. Yep.
Okay, and they're like a lab, right? Or
They are a lab. They're owned by Roche,
okay,
and they will. But talk to your urologist about this and ask him if he thinks you need to do both somatic and inherited. And somatic is what you make yourself. Inherited is what you inherit. Germline.
okay,
It's also called germline. And ask him, and if he says yes, you need to do both, let's start with the germline. Say to him, no, let's start with the somatic. And if we
okay,
see something in the somatic, then we can go in and check if it's germline. Because germline will matter for you, for your kid and for your relatives.
okay.
Thank you, Tony.
Thanks.
Thank you.
And actually, we're back to you, Tony.
Okay, just a quick comment for Lee on insurance. The exclusion portion of policies really does expand the coverage quite a lot. So a lot of times you can look at that and switch it around for how the insurance company is approaching a denial of a claim or something. So I had some questions. I'm trying to wrap my arms around radiation cystitis, and I completed 38 treatments of radiation in the pelvic area 2 years ago, and I just started with radiation cystitis 3 weeks ago. There was a moderate amount of bleeding, but not excessive, and the doctor did a cystoscope 2 weeks ago and discovered what it was, and then last week he did another scope, but this time he did cauterization and a couple of biopsies because he thought there was some questionable nodes there, so he wanted to be on the safe side. From what I'm gathering, the radiation has weakened the interior wall of the bladder, and I don't know what the progression of this is. What I have now, if it's reducing, is that going to be the extent of it, or does it eventually get worse as time goes on? And one concern I've got, my GU medical oncologist had ordered a CT urogram scan for me for next week. That was arranged prior to my coming up with this. And I'm just wondering if more radiation from the CT scan would further complicate or compromise the bladder wall, and maybe I should just delay that CT scan. So that was one question I had on it. And I was reading some other places where they don't really recommend doing biopsies of the bladder wall from radiation cystitis. They prefer to do a urine biopsy. And so I just questioning whether getting the regular biopsy done was a good move or whether it should have been a urine biopsy. So if anybody has any thoughts on those two ideas, I'd appreciate it. I haven't gotten the results of the biopsy he did last Thursday yet, so I'm not sure, but he did cauterize quite a lot of the area.
Your hands up.
Yes. The first thing is I can tell you is that radiation is the gift that keeps on giving. As I said, mine was in 2016, beginning of the year, and the reactions come and go. I have had months on end, stretching almost to a year with nothing, and then I get a little bit here and there. As I said, I had a reaction in May that lasted 2 weeks, and I just had one a couple of weeks ago that lasted almost 2 weeks. 2020, I developed a bladder fistula that, unfortunately, with the problems of COVID, it took a while to get treated. I wound up with massive infection of the pelvic bone and a huge infection in my upper thigh. All of that corrected by a fairly brilliant surgical team at Hopkins when I finally got to them and worked my way through the COVID maze. Since then, I've had very little until what's happened recently. And again, as a result of that surgery, I have a suprapubic tube and indwelling catheter, which actually makes life simpler in a lot of ways. I doubt there are many of you guys who don't get up twice during the night to go to the bathroom. I don't. I hang a bag on the side of the bed and sleep like a baby. So there's a silver lining to everything. But you'll have good times, you'll have bad times. Keep an eye on it. Mine got terribly out of hand during that period when I couldn't get treatment. But ultimately, it's annoying. It's not going to kill you. And you can lead a pretty active life. As I said, our active life, I'm retired, been so for a couple of years now. We do very active travel, and it doesn't get in the way. I travel with a bag full of bed bags and leg bags and whatever else I need, and you just deal with it as it goes. The bottom line is, it's almost 9 years later, I'm alive, and without the radiation, I probably wouldn't be. So at the end of the day, it was worth it. Does that help any?
Yes. Yeah.
Yeah.
As far as getting a CT scan, does anybody have any thoughts on getting a CT scan that could further compromise the lining of the bladder?
Let me add a thought on that, and you might still be available free. Journal of the American Medical Association, maybe 3 or 4 months ago, had an article, the bottom line of which was CTs are a little more serious radiation than we always thought it was, but they're nothing. I mean, they are minuscule compared to what you got for radiation therapy. So they're still small, but they're something that we all probably ought to be thinking about more so. And if I can find a link to that article, I'll post it either this week or the next time this group gets together. But it did raise a concern that CTs were a little more concerning than everybody thought they've been for the last 10 years.
Brian Hack, your hand's up.
Yeah. Well, I didn't have cystitis, but I had 25 sessions of radiation therapy, developed chronic proctitis and dysuria. So it lasted a long time. I thought I was never going to get over it, but a couple things I think definitely helped. And I don't know if this applies to, inflammation of the bladder, but inflammation in general, perhaps. I was prescribed 5 milligrams of tadalafil, which help dilate the distal peripheral capillary beds, and used for ED. But in my case, it was just for perfusion. And I also started to just, and this was off label, or it was more or less just trying something different. I was mixing about a teaspoon of turmeric with some green tea every morning, and it will color your teeth, but you brush your teeth and you'll be fine. But I think the combination of some anti-inflammatories and some vasodilators, I guess, really helped get oxygenated blood to the part of the body that needed healing. Now, your mileage may vary, but it was about 2 years ago, I completely resolved all of my pain issues. And the dysuria only hurt when I was peeing, but the proctitis was with me from the moment I woke up to the time I fell asleep. So I understand where you're coming from, but I think like it's a slow process, but hopefully you'll get there. Those are just my suggestions, and there's no FDA guidelines on turmeric. Just use common sense, but you do have to mix it with black pepper in order to get the full effect. And if you try that, let me know how it works. That's it.
I was using turmeric in the past, but had to stop because I'm on a blood thinner for a heart valve replacement. So the anti-inflammatories are a good thing to consider, but you've got to look at all the aspects and the interactions that they have with your other medications.
Right. Do they put prosthetic valve, or what do they put? What are you on?
No,
blood thinners
for a heart
life?
valve. For a heart valve, I have.
You're on blood thinners for life.
Yes. Yep.
Mechanical, probably. Okay. Good to know. Maybe the tadalafil will help. Are you on Flomax? Or
No, I've had a prostatectomy, so I don't have any need for
well, I
that.
was thinking it relaxes the bladder too, so maybe something along that line might help. I don't know.
And what do you say?
Yeah, thanks, Ben. So, Tony, what I was told by my radiation oncologist is that a pelvic CT scan is equivalent to about 1 to 2 years of everyday background radiation from cosmic rays, radon from the soil. 1 to 2 years of cosmic background radiation is equivalent to a CT scan, pelvic CT scan. So I would say that's pretty low. I mean, you've been on this planet probably, I don't know, 60, 70 years, whatever it is. So, an extra 1 or 2 years, not going to make a big difference.
Mm-hmm.
Of course, you have to, measure the risk-benefit ratio. You're taking the CT scan for the benefit of some diagnostic purpose. So that should, I would say, outweigh the concern about how much radiation you're getting.
Okay, thank you. Thanks, Len.
Sure.
Did you ask your doctor about this, Tony?
No, this just came up on the portal, so I haven't talked with him yet on it. The other part of the question was as far as biopsies are concerned of the bladder, if you have radiation cystitis, are those something that you should try to shy away from?
I mean, you've had the biopsy, right?
Yes.
Okay.
He wanted it done in a hospital setting, but his staff messed up and ended up doing it in the office, so he couldn't get as deep of a sample as he wanted to. So maybe that was a good thing. But yes, he did do that.
Lee Balin, you wanted to comment again? Lee?
Yeah. Yep. My hand's still up.
Yeah.
I'm sorry.
Oh, okay. My fault
How
for
do I
not
take
taking
my
it down.
hand down?
It's down. It's down. You're
Wait a minute.
clear.
Is that it?
My fault.
Lower my hand. There we go. I got it. I think I've said my piece on radiation cystitis.
But do you have any experience, Lee, on biopsies versus
Oh,
what this
no,
biopsy from the bladder wall or anything like that?
no, not had a bladder biopsy. When I saw my urologist back in May after that 2-week bout, he was even reluctant to do a cystoscope. He was, I guess, his word. He said, in his words, he said, "I've been inside your bladder. I know what's there. This is radiation cystitis. If you want, I can do a scope, but I don't recommend it." So he's pretty confident, and I think he's right. Now, look, there's always I'm sure, the very tiny chance that somewhere there's a bladder cancer growing, but I'm 82. It'll take a while.
Thanks for everyone's input. I appreciate it.
Yeah.
I mean,
And
Tony,
another endorsement to Mr. Balin's, Councillor Balin's attitude here. We love to hear that attitude, man. Woof.
to Tony, one reason, I mean, I would speculate the reason that you'd read that about the biopsies is they're concerned about scarring of the bladder due to the radiation, and they, it's the stories we hear about surgery, prostatectomies after radiation. It's scarred tissue, and perhaps they're reluctant to cut it because of they're worried it won't heal as well as you would
And
want.
and Ben, I failed to mention this before when I was talking about Matt being opposed to colonoscopies and what have you. But the reason that this is really for Bob Alvord, the reason they don't like to do it is because it significantly increases the risk of a fistula.
Okay. Henry Cornelius, you're next.
I can wait till if Jeff wants to go ahead and go. Good. Okay. No, I mean I wasn't being a smart ass. I just was trying to be polite. So I've got I'm at high risk biochemical recurrence. My PSAs have started trending up and now are 0.24 from 0.1 over the past 7 months. And that's post prostatectomy and salvage radiation. And the question that I've got is about adaptive therapy, not intermittent therapy like the Embark study, and not bipolar androgen therapy, but adaptive therapy that is being done down at Moffitt.
Right.
Down at Moffitt Cancer Center. I actually have an appointment set with them in 2 weeks. And I just want to know if anybody has any experience with it. Is it ready for prime time? Anything that y'all can help me with. Just a quick recap. I was 54 at diagnosis, PT3BN1, so bilateral seminal vesicle invasion, extra prostatic extension, positive margins, 8 of 27 metastatic nodes, et cetera, et cetera. So it's pretty high risk. So that's it. Adaptive therapy. Any comments? Knowledge?
Anybody here done it? I think it's really exciting. I'm glad you're gonna try it. I'd love to hear.
Well, no, I don't know if I'm going to try it. I'm going to go listen
Ah,
to what they've got to say. I mean, I've got um, the medical oncologist that I mentioned it to, surprisingly, have not have never heard of it, and that's at 3 comprehensive cancer centers. Um, like the real deal. And no one's heard of it. They want to talk to me about intermittent, like the Embark study or bipolar. And so I don't know if I'm gonna do it. I'm gonna listen to what they've got to say.
what did you like about it?
I mean, they did a study in hormone resistant prostate cancer, and some of the guys were still cycling on and off, for years and years. And the theory of it is, and Lynn, correct me if I'm wrong, or anybody else correct me if I'm wrong, but the theory of it is that once you're at an incurable disease state, which I am now, because I've exhausted local treatments. The idea is to live with and manage the androgen sensitive population of cancer cells so that they outcompete, hopefully, the resistant clones to put off the hormone resistant disease state.
Yeah,
It's very well explained, Henry. You got it.
yeah.
I mean, I'm amazed. I mean, I don't know. I've treated at MD Anderson. I've treated at Dana-Farber up in Boston, where I had my radiation. My local place in Birmingham is UAB, which is one of the 53 NCI designated comprehensive cancer centers. And, it's a mystery. I mean, and the guy, Robert Gatenby, Gatenby, has been around for a while writing about this. And so my wife has said to me, well, maybe it's not the real deal yet, since all these other places aren't doing it. And I just assume it's not monetized. No offense to anybody. I mean, but anyway, that doesn't matter what I think. Does anybody have any knowledge about it that they can share with me?
Henry,
So-
there's a member of our group who I believe prefers not to be mentioned on this public call, but I will put you in touch with him. He's very much into this adaptive therapy. He's read a lot of Gatenby's material, and I'll be calling you too as well. But
Okay.
I'm sure he would love to talk to you, and you'd love to talk to him.
Yeah, I'd love to, and I'll report back. I'm meeting with them. I emailed Robert or Dr. Gatenby, and I've got an appointment with his colleague, a medical oncologist, last name Zhang, who if you Google the term adaptive therapy, you'll get Zhang as a PI or co-author,
Yeah.
and all the stuff. And I'm meeting with them on the September 15th, and supposedly they've got something called an evolutionary tumor board and so I'll report back afterwards. I'm not going to make any decisions. I just want to hear what they've got to say. Thanks, Rick. Go ahead.
So a couple of things. One is that Gatenby just did a presentation on cancer patient labs that I think Ben and I were both part of. Well, attended. I'm not sure I got it as clearly as Ben and Len did. And I am just looking for the link because they do publish all their stuff. They put it on YouTube, and I'm just trying to find the link on YouTube, and I'll put it in the chat window. And Jim Marshall is asking, can we explain it again in simpler language? I thought Henry did really well, but we can definitely explain it again, but I can't. It's either got to be Ben or It's either going to be Ben or Len. So who drew the short straw here? Because I can tell you I can't do it.
I'll give it a try, and then Ben, you can chip in too. But no, what I have to say is not much different from what Henry said. But if maybe this will help, if you think of the typical strategy for fighting cancer, particularly prostate cancer, is you want to drive down the PSA to obliteration. You want to completely wipe it out. So the adaptive theory says, well, hold on, guys. If you do that, what you're left with are cells that are resistant to whatever therapy you're using to wipe out those sensitive cells. So the theory is you don't want to wipe them out completely. Maybe just knock them down enough so that eventually they'll recover, and they'll recover sufficiently to outcompete the resistant cell populations. Now, why would they be able to do that? Well, again, the theory is that the more resistant cell populations have had to make mutations to make them resistant, but it also requires them to have higher energy needs. So the more sensitive cells have lower energy needs, and so they should be able to outcompete the more resistant cells. Then give it a shot.
Oh, I mean that's really great. Um, One point to notice is that this presupposes that all of these populations are already there. I mean, it's
Yeah.
easy to think resistance develops because one one strain succeeds another, and that but actually there's a big family of mutations, each um, and they are as just as Len said in competition, and right you want to in the predominant strain, of course, is driving your cancer, but it can also be your friend. Um, as Len said, you knock it down and thereby knock down your cancer, but you leave enough of it so that the resistant strain still has some competition. Otherwise, the resistant strain has no competition. It can become the your new cancer. I don't think I improved on what Len said. Um, Jim, your hands up.
Excuse me, guys. You say then, or competition. Competition for what?
Survival.
So, yeah, these guys all
Competition
need.
for survival. In other words, is the weaker one consuming more of the energy than the other ones are? And it's sort of, it's a pig essentially at the head of the line.
Now, the sensitive cells are the ones that consume less energy, so it's easier for them to survive. They
Okay.
can survive on less energy. The more resistant cells require greater amounts of energy, and therefore they're at a disadvantage when trying to outcompete the sensitive cells.
Okay, thank you.
Yeah, I mean, you can think of them as living in different neighborhoods, and one neighborhood is going to grow and grow at the expense of another.
But if you carpet bomb the tumor, which is the current, you know, I guess approach, you carpet bomb everything. The sensitive cells, the AR sensitive cells, against which ADT or abiraterone or enzalutamide or darolutamide, et cetera, initially work. I've read in these papers and listened to the podcasts of these guys, something called competitive release occurs because all the androgen sensitive cells are driven to extinction, and then it allows the resistant population that are androgen indifferent to really blossom and have a free reign out on the Serengeti to prey on everything it will.
Yeah, and it's worth noting that this is not pure imagination, that actual behaviors like this are observed both in things like pesticides and in natural evolution. That these are based on historic models and not just something that's been dreamed up for the sake of cancer. He's
Thank y'all.
Yeah. Hey, David Muslin, you're next.
Thank you, Ben. Scott, I was started back on darolutamide after a year and 3/4 of a holiday and dealing with some extreme fatigue. And I wonder if that, I never really felt it the first time I was on Dara, but I was also got on Dara right after being on Lupron. So just being on Dara by itself, I'm experiencing some fatigue. Wanted to share that and see if I can get any feedback if other people have noticed that as well after a holiday. That's one piece. When you answer that, I'll bring up the next piece.
Go for it, Len.
Oh,
Yeah. So, yeah, David, as you know, I've been cycling darolutamide monotherapy for years, and a good friend of mine, Peter, also doing the same thing. And we both had the same experience that you're going through now. We've had a time on darolutamide where we felt like we were taking a placebo. It was that good, very little fatigue. But I would say after cycling like this for a few years, all of a sudden when we restarted, we found that the fatigue had increased substantially. And we're not really sure why. I asked Dr. O about this, and he said he thought possibly it's just a cumulative effect of, over the years, you keep getting this androgen receptor blocker, and after a while, it catches up to you, and you feel the fatigue.
Yeah, it's exactly what I'm experiencing.
So yeah, what you're experiencing is not uncommon in my experience.
Okay, good. And the second piece is I've got gynecomastia is coming back, and I can.
Hold on a second, David, on the first piece.
Yes,
before
sir.
we go to the second one. Len, how long did it take you to get over that extreme fatigue and before you felt like you got back to normal?
How long did it take for me to feel the extreme fatigue
No, how long did it take you to get over the extreme fatigue?
Oh, not until I simply stopped taking the darolutamide.
So you had that extreme fatigue all the time that you were on the drug? It didn't go away?
In the later stages, Rick, yes, like let's say the third cycle or fourth cycle, whatever it was, of going on and off monotherapy and drug holiday. Probably, third or fourth time, I all of a sudden said, "Wow, what's this? This drug is making me tired," and it continued to make me tired until I stopped taking it.
Okay. And does anybody else, we'll come back to the gynecomastia for sure, David.
Okay.
Does anybody else have experience of cycling on and off of either darolutamide or one of the other drugs, and when you cycle back on, you have extreme fatigue?
Rick, let me just clarify. To use the term extreme, I mean, it was no worse than the fatigue I felt the first time I took abiraterone or even bicalutamide, which I took only for a brief period of time. So, but the point is, there was fatigue, and I never had that before with darolutamide.
So what you're saying is the first time you took the darolutamide, it didn't affect you very much, but then you went off it, took a holiday, came back on it, and when you came back on it, you experienced significant fatigue.
Well, it was at least the third time I was recycling, not the first two times.
So the first two times you went on and off, and you
On and
were
off with no problem. The reason
no,
I'd
no,
stopped is because the PSA was undetectable.
okay.
Yeah.
Second cycle for me, and I'm feeling extreme fatigue. But I'm living with it, like I've done before when
It
I was
Mm-hmm.
could
on
be,
Motrin.
it could also be because we're older. We have more sarcopenia, more muscle weakness. You know, all of these things are cumulative that could be contributing to the fatigue when you go back on.
So I want to come back to the muscle weakness too, but I think Dennis has his hand up relative to this point.
Yeah, I get fatigue when I restart after taking a break, but I'm on ADT on an Eligard also, and the Eligard, stops the production of the testosterone, which is why I attribute that to my fatigue and slightly more weaker when I go back on that. The darolutamide didn't seem to be, that doesn't stop the production of testosterone. It's a blocker, right?
Mm-hmm.
So
Okay,
Um,
Rick, can I just, someone sent, I think it was a private, um, Brian sent me a private text, and he's saying, what is your testosterone? That's an important point that I forgot about completely. Once again, over the years, I would be cycling on darolutamide, and my testosterone was, 400, 300 in that range when I went on while I was on darolutamide, and then, of course, when I was off. Now, for the past couple of years, I've been more off therapy than on. Despite that fact, my testosterone has continually drifted down to the point where the last T level was 99. So, that may also be a reason why. Do you know what your T level is, David?
I do. It's about 450 right now.
Oh, yours is good and high. Okay, so Dr. O said he doesn't know why mine is drifting down like that, but it has over the past couple of years. Even when I'm not on therapy, it just keeps drifting down. That's probably a large factor in why I'm feeling the fatigue when I go back on the drug.
so there's two more issues. One is the gynecomastia, which we'll talk about. I just want to make a comment on the sarcopenia. We talked about it very briefly last week, and I think I put a link in, and I'm going to try and post something in the reminder. But there's this study that came out recently that suggests that cancer cells this protein called activin A. And when the cancer's active, it produces more activin A. Oh, fuck! Excuse me. Whoops. Can you guys hear me?
Yeah.
I'm sorry about
in all your
that.
profane glory, yes, we heard every single
Yes,
syllable.
in all my profane glory, because every time I start speaking, I lose a connection. It's drive.
No, we heard that loud and clear.
they're frozen.
Oh, I
Oh,
think
now
we
you're
lost.
frozen.
Now he can swear again.
Oops.
While nobody's talking, let me ask you a question, David, Len. You got this PSA, you got this testosterone floating around, nowhere to land when you're on darolutamide. It's just floating around in your blood. And I just wonder to what degree it has any activating value when it has nowhere to land as far as receptors. Number one. Number two, as we get older, most of the testosterone is bound to, proteins and have you found out how much of it is free and available and how much of it is bound? David.
David, go ahead.
I don't know how to answer that question. I don't know if I understand the question.
You get a testosterone and you ask the doctor to determine how much free testosterone you have and how much is not free and how much is bound. So you know whether or not it's affecting you and helping you.
I can look it up, but I don't know the answer to that question.
So, Jack, I can tell you, I've never had the free testosterone checked. It's never been ordered. And I asked Dr. O the same question you're asking now. I said, okay, so I've got all this was years ago when the testosterone was high. I've got all this free testosterone, floating around. And if it's being blocked at the receptors, what good is it really doing me? And he says, well, it's not a complete blockage. You do get some testosterone, leaking into the cells. So that was his answer.
Enough to give you some energy and strength that a testosterone ordinarily will give.
Yeah, it's kind of theoretical, I suppose. I'm not sure anybody really knows.
I mean, there are also pathways that don't involve the androgen receptor, non-canonical pathways.
Yeah.
So it's not all wasted.
Right.
Okay, it's almost 8 o'clock. We have 3 more people to go.
All right, let me just finish up with the gynecomastia there.
Yeah. Everyone know what that is? Is there anyone who doesn't know what gynecomastia is? Okay.
I thought you had a bilateral mastectomy.
I did. That's my question. I did have it, but my boobs are sensitive, and I can feel a little, and it's swollen around the nipples, maybe as large as a $50 or something. I can't give you the size.
Did the surgeon say he left some breast tissue in there when he did his surgery?
Maybe he did, maybe he didn't. I didn't ask him, so I don't know. But I'm going to go see my radiation oncologist at Northwestern on Thursday, and hopefully he can blast my breasts, which I never had done. But it's absolutely very sensitive and a little lump behind my nipples on each side. I don't know if anybody else has experienced that after having gynecomastia surgery or second round.
Hands up.
Yeah, I have it too, David. Just on one side, gynecomastia. The nipple gets very sore around there, and I've been told just to use a little bit. For me, it's just I haven't had any no incidence of cancer growth or anything or surgery there. So I've been told just to use ice, which a little ice pack on it for a little bit. 15 minutes works.
Thank you, Dennis. Len, have you ever experienced that on mono therapy?
When I first felt some nipple tenderness, then I did have radiation to the breast. That was about a year ago. And that took care of it. Now, I was talking with Dr. Shellhammer about estradiol, and I was asking him about, how did you deal with the gynecomastia? And it's probably better for you to hear it from him, but he told me that he had a type of plastic surgery that surgeons use on women with breast cancer and have like I think Ben or someone or Dr. Jack said, they leave a certain amount of breast tissue there. So so he had the surgery to remove the areola. I don't know the exact terms, but that worked for him at any rate. So maybe that's what you need to do. You should talk to Dr. Paul.
Thank you, Lynn. Thank you, everybody.
Thanks, David.
Sort of below the areola without removing the areola. The areola is the nipple. You're not going to have your nipples removed. But maybe the subcutaneous breast tissue that was left beneath the nipple, and maybe they didn't remove that, and that has to be removed.
Yeah.
So you don't get the tenderness affected by the hormone.
Question, David. How long ago did you have the surgery?
January of this year.
Of this year?
Yes, sir.
And did the discomfort start before you went back on darolutamide or only after?
No, after. You know, it was crazy. I was talking to my med onc and following up with him 30 days after. He said, how are your nipples? And at that time they were fine. And sure enough, a week later they started hurting me. And he suggested either getting on tamoxifen or get them radiated. And I much rather I think it's just one quick shot of radiation and it's over, right, Len?
In my case, it was 2, but
Two.
Sometimes they do 1.
Okay.
In my case, it was 2 also. And it sort of stabilized things. It didn't improve things, but it stabilized things.
Yeah. If I can get it to stabilize, I'd be happy. A little bit of growth, but they're much better than they were, way better than they were. Thank you, man.
David, I'll forward you Dr. Paul's email to me where he explains what he did, okay?
Thank you, Len.
Hey, thanks, David. Jeff Markey is up.
Yes, I've had 2 things happen since late July. One of them is, if you can see this here, that is my weight. For 20 plus years, I've weighed 189, 190. Mid-July or late July, you can see this drop all of a sudden, and I've eaten more and more, and I'm not gaining any weight. At the same time, my blood pressure had always been, for the last year or more, had been around 100 under and systolic and under 60 diastolic. Starting around the same time as my weight dropped, my blood pressure's gone up from at more like 120 to 140, and the diastolic around 70. So both things have happened at the same time. I changed no drugs that I'm taking. I just am puzzled. I was told that it might be due to the lack of water with like Gatorade, that type of water that has
Electrolytes.
electrolytes in it. Yes. So I tried drinking a half gallon of extra electrolytes for a couple of days, and I got a little bit of bounce one day and then went back down the next. And I haven't lost my appetite. So Caxia doesn't seem to be like a possibility because I haven't lost 20 pounds. I've lost about 6 or 7. And I'm just puzzled as to why my blood pressure would go up and my weight would go down at the same time. Is there and anybody know of some correlation between that and prostate cancer issues, the drugs we're taking?
So have you talked to a doctor?
I actually have the email going out to my oncologist tomorrow. She's been away for a week. It's the last few weeks, 2 or 3 weeks, I tried to eat more and
Hmm.
do other things to try to resolve this issue, and nothing's doing it. And I will also speak to my cardiologist about the blood pressure issue. But I had a Holter monitor about 3 weeks ago, and the results were pretty standard. Almost nothing abnormal. Any ideas?
Your blood pressure went from what to what? You said
Well, it was around 100,
60.
100 or
It was what?
160. Shoot, I went in to get surgery at Kaiser, and it came in at 86/49, and they were a little upset. In fact, they didn't even
That's
write it
upset.
down right. But
Uh,
it's almost always been systolic around 100 or less, diastolic under 60, and now it's 120 to 140, and the diastolic around 70. Of course, that's not dangerous, but it's, what's going on? And that's what I'm wondering. And I thought somebody here might have an idea, but
120 to 140 is, of some concern.
well,
But,
it went from 100 to up, pretty steady for over a year, around 100. And I've never had any fatigue from it. I've been fine. No,
somebody who has a long-term history of you should be examining you like your primary doctor or somebody. You have a primary physician?
yes. And I get a lot of blood tests every month, and nothing's changed. It's stayed the same about for over a year.
I just wonder if it is related to the long-term use of ADT and ARSI drugs. And that's where I'd be going with Dr. Hartstock. And if there is anybody at Kaiser who is specialized, any cardiologist who's specialized in oncology, and I'd be talking to them. I mean, what we would say if it wasn't Kaiser was go see a cardio-oncologist. You've been on these drugs for how long, Jeff? 7 years, 8 years? How long have you been on them?
It's been 9 years on ADT, and I've been on, between Abby and darolutamide, it's been about 6 years. 5 years.
The accumulated impact of these drugs could be catching up, and that's going to require somebody who really understands the impact of these drugs and metabolic syndrome, and you need as a cardio-oncologist. I'm pretty sure there are a couple of guys over at UCSF, but you need a cardio-oncologist, and to try and get to the bottom of this. That would be my response. Anybody else have any thoughts on that?
I will contact some people tomorrow.
Yeah, be interesting to hear what these things are connected and what they are.
Thank you.
Thanks, Jeff. Kavanaugh, you're next.
I don't have any answers to Jeff's, but I've experienced high blood pressure, and I've been on the Orgovix for 8 months. I just came off of it. I've suspected a lot has to do with the Orgovix. I've lost weight, but not as substantial as you, but I'm down to 123.4, which is 7 pounds down. So it's similar, but not the same ratio. I've also been in contact with Dr. John, who's as Rick said, is flying from Vancouver. So he's detected some things in terms of my sleep apnea study, which is separate from the prostate cancer, but it all blends together. I want to thank Rick for basically trying to contact and set up a visit with the medical oncologist. And I want to give a salute to Captain Jim. Basically, I saw his email today. I'm so impressed by his story and all the people that are working on AnCan. And God bless everyone.
So, Jim, we'd really like to try and brainstorm this a little more with you. I know Dr. John really wanted to do that tonight, but he couldn't be here.
Yes.
But it ties in so much to what we've been talking about tonight with the fatigue and with several guys and the weight issues. And although you haven't been on for a long time, although you are older, I don't know. First of all, you don't have to thank me until we get some results, and I'm sure Chuck Ryan will respond to me at some point. My guess he is away. We'll hear from him, and if we can't get to Chuck, we'll go somewhere else. We've got other people. The worst that happens is we have to match you to somebody in the city rather than in New Jersey. But this extreme fatigue, your urologist's response to it is, well, we'll just stop the drug. Is that right?
Yes, he basically said it's my choice and that he would look at the labs in 3 months and then consider Lupron. But I really need second opinions. I'm not happy.
So, I mean, maybe you're not on a proton pump. You don't use a proton pump inhibitor, do you, Jim?
No.
Okay. Because we do know that Orgovyx doesn't play nice with a proton pump inhibitor. Otherwise, I mean, I'm not really sure that changing, it may have an impact, but changing the type of ADT is sort of a bit of a fishing expedition. And so if he really feels that you should be on some sort of drug, I would be talking to him about a monotherapy application with one of the ARSIs. I mean, there's a study using monotherapy enzalutamide that's been was promising. We know you can use monotherapy darolutamide. Thoughts? Anyone? Don't all shout at once.
I can try to engage him prior to the 3 months, but I certainly can't wait the 3 months. He seems to be overpowered in terms of number of patients he's handled, and I'm really going to have to push him. But it's really at that stage.
Now, what about your radiation oncologist? You're talking to your urologist, isn't that correct?
That's correct.
Now, but you recently had radiation, correct?
It ended February, and my next visit is November. I can try and move that up.
Well, a lot of times it's the radiation oncologist that prescribes the hormone therapy and not the urologist.
Yeah.
So we would rather see a medical oncologist involved. We'll work to get one. But another alternative is to go back to the radiation oncologist and ask for an appointment with him and see if he can help you better manage what is going on and talk to him about monotherapy.
I can do that and will do that with her.
and you know that's definitely another option. Um, through your insurance, do you have access to these GU medical oncologists?
I have Medicare, and that's my primary. MRI Health is my second one. Normally,
So
Medicare approves everything.
right, but here we've got an issue with. Is it traditional or is it an advantage plan that you're on Medicare?
All I know is it's a secondary plan. After the 80%, the 20% is normally covered.
And do you have to have them approve the doctors, your secondary?
The secondary normally just happens, although I just had an eye doctor who basically is going to drop the secondary and change. So I may have to change.
Okay, because if you're on traditional, you can pretty much go where you want. But if you're on an advantage plan, you may not be able to. And so, and then the third way is to go through the VA, which Jim is very well aware of. And if we got you in and through the VA, we could probably get you to whichever docs we wanted. But then you have to be. Are you dual registered right now, Jim?
No, but I had put in the intent to file for the MS type thing because there was an arrangement that Jim mentioned that you can go through the healthcare piece of it as opposed to the other VA system, as I understand it.
Well, I think that you might. First of all, you need to check your medical insurance and see whether it's an advantage plan or not, and whether you're restricted in which doctors you go to. So that's sort of one piece of homework. If it turns out you are restricted in the doctors that you go to, then we need to get you enrolled in the VA as quickly as we can. And these are a couple of avenues to move down. I mean, it may well be that, yeah, Chuck Ryan says, okay, I'll see him, but your insurance doesn't cover you.
Right.
So we need to check that and take a look at this. Who did you say your secondary insurance is with?
Ameri Health. AMERIHEALTH.
Okay, well, call them tomorrow. Find out if you're on an advantage plan or if you can go to any doc that you want.
Okay, will do.
Okay, and then let us know, and then we can help you from there in trying to figure out the best way for you to get to a medical oncologist, and also definitely set up an appointment with your radonc and ask her about what she would do. I'm sort of concerned that your urologist is washing his hands of it. Is your urologist in a community practice?
He's attached to the hospital, but he's simply overloaded, in my opinion. And 3 of the staff members have admitted that.
Okay, which hospital is he attached to?
Morristown Memorial Hospital in Morristown.
So that makes him a community. That means he's a community oncologist, because Morristown is not a center of excellence, as best as I know.
Okay.
Is that right, Ben? Is Morristown affiliated with any centers of excellence?
I had not heard that. I don't know.
Okay, you don't know either. So, I think that it's another problem with these urologists, especially since they're not making any money on you because you're taking Orgovix.
Yep.
And I don't. It just sounds sketchy to me that the answer is, well, let's switch you to a different ADT when the Orgovix has washed out your system, which doesn't take very long, by the way.
Right.
What's the half-life of Orgovix, Ben?
Oh, you hit me with all the questions I can't answer.
25 hours.
Len, do you know what
25 hours.
The half-life of Orgovix? It's not that long. It's not like the The deeper
25 hours. 25 hours is the halfway.
25 hours, Jeff Marchi says. So that means that this Orgovix, once you stop, it'll wash out your system quickly and your testosterone should come. What was your starting level of testosterone before you started the Orgovix?
I don't know what it was before, but the testosterone is less than 0.3 and the free testosterone is 0.7.
Yeah, but you see, that doesn't help us. This is why, gents, who's ever still on, and whoever's listening on the recording, this is exactly the reason why we always tell you guys, get a testosterone reading before you start taking hormone therapy. Because we don't know where Jim was before he started, so we don't know what we've got to get him back to.
I'll go back through the records and see something, if there's something in the MyChart system with my regular primary.
You don't remember if they ever tested? A lot of them never test testosterone.
Yeah, I don't know. I'd have to look.
Yeah, I mean, don't be surprised if you don't find something.
Yeah, but I will look and I will follow up on your two suggestions. The other complication was my sleep apnea equipment was supposed to come in and start on Monday, but Dr. John was wise enough to raise a question that I'm going to ask my cardiologist tomorrow, whether my left ventricle will basically be able to handle this type of equipment because of my heart history. Something I would not thought of.
Well, God bless Dr. John for, looking into that for you. But he did ask me to make sure we talk to you at some length today.
Yes, he did mention that.
So I'm sorry we got to you so late.
No, it's not. It's not at all. I just felt everyone else was more important and more complicated.
No, that's not the case, Jim.
Okay.
It's not the case. Not everyone is more important. You're just as important as most of the other guys in here, and we want to give you the time. It's just been a rough night.
Yep.
I've had it, as you heard. I apologize to everybody for swearing, but it's like each time I try to say something, the platform kicks me off.
Understood.
So it's been a little annoying tonight. I've probably been kicked off about 6 times this evening, or 8 times. All right. Does anyone else have anything they'd like to say to Jim? Nobody wants to reassure him that he's just as important?
Of course, you're just as important, Jim.
That's my take, Jim. That's my take. All right.
Well, Ben, before we close, I just want to get this on the recording because when Jack asked about what's the benefit of having testosterone floating in your bloodstream when your receptors are blocked, I forgot to mention the fact that, at least in the case of darolutamide, it doesn't penetrate the blood-brain barrier. So testosterone is getting to your brain, at least. That's important because that affects your mood, your motivation, your emotions, so.
Great point.
Yeah.
Mm-hmm.
Really good point. Really good point, Len. Really good point. Okay, Ben, hold on a second just to talk logistics when we stop. Okay.
Okay, we have actually cleared the deck. And
good, great job.
Thank you, everyone, for joining. And I will
Thanks, Ben.
Thank you, Ben.
Thanks, everybody.
Thanks, Ben.